Welcome to This Explainer. Today, we're focusing on what's arguably one of the most fundamental yet absolutely fascinating aspects of the physical exam, the physician's guide to split S2. We are putting our ultimate investigative tool, the stethoscope, front and center to decode the heart's famous DUP. Now, we all know the classic lub-dup sound, right? But there is literally an entire world of hemodynamics hiding right there in that second syllable. Okay, let's dive into this. What is your stethoscope actually telling you when that single, crisp DUP splits into two distinct sounds? You know, it's incredibly easy to just memorize a list of heart sounds for a board exam and call it a day. But today, we're going to transform that rote memorization into a deep working understanding of cardiovascular mechanics. We're going to learn how to listen to the heart and visualize exactly what the valves and vessels are doing in real time.
So here's our quick roadmap for today. We'll start with the mechanics of the DUP, then move into the hangout interval, explore volumes and pressures, decode the split, and finally bring it all back to the bedside with auscultation in context.
Let's get right into it with Section 1, Mechanics of the DUP, laying the baseline. Because before we can start diagnosing complex pathologies, we have to establish the absolute foundation of what we're listening to at the precise end of ventricular systole.
So, the second heart sound, or S2, is that familiar DUP. It marks the definitive end of ventricular systole and kicks off the very beginning of diastole. Acoustically speaking, it's a high-frequency sound, measuring right around 120 to 150 hertz. And mechanically, this sound is produced by the closure of these semilunar valves, specifically the aortic and pulmonary valves.
But here's something absolutely crucial to understand. S2 isn't just some physical flap closing randomly. It's a precise, dynamic event driven entirely by pressure. It happens at a specific tipping point called the pressure crossover. As the ventricles start to relax, their internal pressure naturally drops, and the exact millisecond the pressure in the great vessels, the aorta and pulmonary artery, exceeds that rapidly falling pressure in the relaxing ventricles, boom, the valve snaps shut. This crossing pressure gradient is literally the engine behind the sound you hear.
Moving on to Section 2, the hangout interval, understanding the why. Because if both ventricles are relaxing at roughly the same time, why on earth do these two valves close at slightly different times?
Well, to answer that, we have to look at a brilliant physiological concept called the hangout interval. This is the brief, measurable time between that pressure crossover we just talked about and the actual physical closure of the valve. It turns out, valve closure isn't instantly instantaneous. The delay depends entirely on two factors: the pressure beyond the valve and the distensibility, or the stretchiness of the vessel receiving all that blood. And this perfectly illustrates exactly why the sound splits. The aorta is a high-pressure, relatively stiff vessel, meaning it has lower distensibility. Because of this, it has a super short hangout interval of just 30 milliseconds. It snaps shut almost immediately. The pulmonary artery, on the other hand, well, it's a much more distensible, lower-pressure system. It's stretchier, so it takes about 80 milliseconds for the pulmonary valve to finally close. This 50 millisecond difference is the exact mechanical reason why the aortic component, A2, normally happens right before the pulmonary component, P2.
So, when we contrast A2 and P2 on our acoustic baseline, the differences make total sense. A2 is produced by the aortic valve closing, and it's normally the louder of the two sounds. Why? Because the systemic pressure in the aorta is just so much higher. P2 from the pulmonary valve is a lot softer because the pressure in the pulmonary circuit is significantly lower.
All right, let's look at Section 3, Volumes and Pressures, the clues to intensity. The big takeaway here is how the sheer volume of the sound acts as our next major diagnostic clue.
When you're listening and you notice that S2 is unusually loud or unusually soft, you're getting direct, real-time clinical insight into the state of those valves and the vessels beyond them. There are basically three broad categories of suspects that crank the volume of our DUP up or down: vascular pathologies, valvular pathologies, and hyperkinetic states. Let's break these down real quick.
Let's compare the extremes. With vascular pathologies, like systemic or pulmonary hypertension, you've got massively increased pressure beyond the valve, or even dilation of the vessel itself. This higher back pressure literally slams the valve shut harder, resulting in a distinctly loud S2. You'd get a loud A2 in systemic hypertension and a loud P2 in pulmonary hypertension. Conversely, if a patient has a valvular pathology, say degenerative aortic stenosis, the mobility of the valve leaflets is shot.
A stiff, calcified, immobile valve simply can't snap shut forcefully, which totally muffles the sound into a really soft S2. But hey, we also have to remember that a loud S2 doesn't automatically equal irreversible heart disease. Sometimes it just means there's a higher volume of flow across the valves. In hyperkinetic states, think of a patient running a high fever or someone who literally just finished sprinting on a treadmill, that increased cardiac output and flow will naturally result in a much louder A2 and P2. Let's transition to Section 4, decoding the split, identifying the culprit. Now, what's genuinely fascinating here is how we use the patient's own breathing to catch our pathological suspects. First things first, we absolutely must recognize normal physiological splitting, which relies heavily on the respiratory cycle. During expiration, the gap between A2 and P2 is about 40 to 50 milliseconds. That is so fast that usually just sounds like one single sound to us. But during inspiration, the negative intrathoracic pressure sucks more venous return into the right side of the heart. That extra blood volume takes a fraction of a second longer to eject, which delays P2. The gap widens to more than 50 milliseconds, making the split clearly obvious to your ear. When that normal respiratory relationship goes out the window, we turn to this high-yield diagnostic matrix. Depending on what you hear, you can categorize the split into 4 distinct types: wide variable, wide fixed, reverse, and single. A wide variable split is heard even during expiration and can be caused by electrical delays, like a right bundle branch block giving a late P2, or mechanical issues like mitral regurgitation giving an early A2. But let's look a bit closer at the heavy hitters. If you hear a fixed split, you are listening to a massive diagnostic red flag. Fixed means the split is wide, but it completely ignores the respiratory cycle. The gap between A2 and P2 does not change one bit whether the patient breathes in or out. This acoustic pattern classically, and I mean almost always, points straight to an atrial septal defect, or ASD. Then we have the bizarre one, the reverse, or paradoxical split. In this scenario, the normal order is totally flipped upside down. P2 actually happens before A2. No way, right? But yes, you'll hear the split during expiration. But when the patient breathes in and P2 gets naturally delayed, it suddenly overlaps with the already late A2 and the split magically disappears. This paradox happens when aortic closure is severely delayed by things like a left bundle branch block, severe aortic stenosis, or hypertrophic cardiomyopathy. Finally, what if there's no split at all? A completely single S2 heard constantly throughout the entire breathing cycle is also super significant. It can indicate severe issues like pulmonary arterial hypertension, where the pressures are just so incredibly high the valves are forced closed simultaneously. It can also honestly just be a normal part of aging, or it could point to a missing or severely diseased valve, like in the atresia of a semilunar valve.
Okay, bringing it home with Section 5, auscultation in context, bringing it to the bedside. Let's see how all this theory actually builds our physical exam skills. Think back to our baseline. S2 is a high-frequency sound, living right in that 120 to 150 Hz sweet spot. Because of this mechanical reality, it is absolutely essential to use the diaphragm of your stethoscope, pressing it firmly against the chest wall to catch these crucial frequencies. If you use the bell, you're going to muffle it, and you might miss the subtle timing of the split entirely.
It's also vital to map out the exact chronological sequence in your mind as you listen. Immediately following the S2 closure, the heart enters a brief phase called protodiastole. That's followed closely by the period of isovolumetric relaxation, or IVR. Understanding this exact sequence helps you properly place extra sounds in the cardiac cycle. Any extra sounds that pop up right after S2 in this early diastolic window, well, they're categorized as early diastolic sounds. That's exactly where you want to listen for the opening snap of mitral stenosis or pericardial knock.
So, I want to leave you with this thought. Next time you hear a split S2 on the wards, which hidden suspect will your stethoscope reveal? By understanding the mechanics of crossover pressure, the physics of the hangout interval, and the respiratory clues hidden in the split, you're no longer just passively listening to a DUP. You are directly visualizing the hemodynamics of the human heart. Take this framework, apply it to your very next patient, and let your stethoscope do the brilliant investigative work it was built for. Thanks so much for joining me on this explainer, and keep listening closely.